Welcome to Ancora Compassionate Care's podcast, Compassionate Conversations. As a community-based, mission-focused organization, we provide hospice care, serious illness care, and counseling services. This podcast is an opportunity to explore topics that touch the heart of serious illness, caregiving, and support. Because every story, every journey, and every moment matters. Thank you for joining us. We're grateful you're here. Welcome to this edition of Compassionate Conversations, where we talk about various healthcare topics that are important to the community that we serve. Our goal is simple: to share reliable information, to highlight valuable resources, and maybe just correct some misconceptions that might surround the topics that we're going to discuss. Today we're going to be talking about what is termed goals of care conversations and advanced directives. Rhonda Lucas is joining me today, and Rhonda is one of our nurse practitioners here at Ancora Compassionate Care, and she also serves as our director of our serious illness care program. So thanks for spending a little time with me today.
You're welcome. Thank you for having me.
Yeah. So let's just start with the basics. You know, we talked about goals of care. So when somebody hears the phrase goals of care conversation, what does that actually mean?
Well, it's true, but in the sense that we use in healthcare, a goals of care conversation involves their provider, whether it's their primary care doctor or provider, or whether it's palliative care, whoever their provider is, and it can be a social worker as well, having a discussion with them about what's important to them now. We're learning more of that with this onset of the new program with, aging and how people in my generation want to age. And we're very more informed than the generation before, and they were more than the generation before that. So being informed is not the only thing. We need to know what is important to us. And so that's basically what that conversation is about. What is important to you right now?
Okay. Why would it be important, though, for somebody to have those conversations or just think about those things, especially before there's a healthcare crisis?
Well, because sometimes a healthcare crisis is too late. So I encourage folks, and my husband and I have had our conversations for years now. Mine started with a cancer diagnosis, but it doesn't require a diagnosis of a condition. At some point, I think, when you have, like when you have children and you decide, well, if something happens to us at the same time, who's going to be their godparents or who's going to be their guardians? It's the same type of situation. So what do I want done to my body and to me as a person and for my family to see if something happens to me? Unfortunately, our family has had 2 deaths in the last 6 months that were unexpected cardiac events. And in both cases, they were treated to the max with CPR, the drugs, the shocking, everything. And it is horrific for families to watch. At one point in nursing, Lynn, they didn't allow families in when a person was being what we call coded in the hospital. And then with the onset of the 80s, they decided that people needed to be freer to be, but it is not anything that anybody wants to watch as far as that goes. So making those decisions, now yes, I want to be resuscitated. I'm not to the point where I don't want to be, but at the same time, I know that if I can't talk and I can't eat on my own, I don't want a machine to do that for me, because that's my quality of life. That's my goal. My goal is quality of life. Most of us that work in this, we know what quality is over quantity.
So when you were talking earlier about what matters most, that's really what we're getting down to.
That's really what it is.
So for some people, it may even be when I'm no longer able to live by myself, when I'm no longer able to travel as I want to, anything along those lines. Some decisions may be made. But I'm sure all of that, so what a person values or whatever that individual's priorities are, that's what's going to dictate how they feel about things.
That makes us ourselves, doesn't it? Our preferences. And so however you, so some people say length of life, no matter what.
Right.
And if they don't say no matter what, I ask them during a goals of care conversation. I say, what's important to you right now? I just talked to patients recently. One lady said, well, I want to live as long as I can. I said, okay, so right now length of life is important to you. Does it matter the cost?
Mm-hmm.
Does it matter what condition you're in? How long? Well, no, I don't want this and this. As long as I can do for myself, or as long as I can eat, or as long as I don't need somebody to help me to the bathroom even. I mean,
Right.
people, their independence is super
Right.
important to them, to most folks. So that changes things, right?
Right.
Because we know that a lot of people, especially elderly or have chronic illnesses, they do not, if they have a fall or an illness, it's hard for them to come back to where they were. And so with each chronic illness, each exacerbation or acute illness, like a pneumonia or a fall with a break, that is, they never really come back up to where they were.
Right.
And so we have to start having those conversations. But if it's already been done, like I've had
Right.
families who, oh, my husband and I talked about that. I'll be one of those people when they interview me, I'll say, oh, that's already taken care of. But, and it's only because I'm exposed to it.
Right.
If I wasn't, and most people are not exposed to it. Most people think that it's going to be like it was on Emergency years ago, or ER after that.
Oh, Grey's Anatomy. That
The next day that they're okay after being coded. And only less than 5% of folks who are resuscitated outside of the hospital survive.
Right.
So,
Well, so thinking about misconceptions. So I think there's one around goals of care conversation that you wait until you're much older to have those. Or, we've already touched on waiting until you have a diagnosis. And again, this comes back to the exposure. So even my children, who of course are grown women now, but they are very used to, from young ages on, hearing us have these conversations. But again, they grew up with, their mom was a hospice nurse. So
same here.
That's where it was coming from. But I would encourage people to, as soon as they become an adult, or you've got a significant other in your life, or whatever the case may be, let somebody know what your thoughts are.
It really needs to be in that conversation, especially if you have children, like we talked about, who's going to take care of those, because that's part of the plan, right?
Exactly.
And having that plan B, what if I'm disabled, but my husband's not? And if I'm in the bed and he's not going to be able to take care of me, which is 99.9% of the time,
Yeah.
especially if they're not retirement age, then do we have money to do that? And all those plans are part of one big goals of care plan. Now, I don't get into all that with our patients from the beginning. Some of that are discussions that I just encourage them to have the discussions.
Right.
And then we come back to what affects, my being their provider.
Mm-hmm.
But yes, the earlier, the better.
If you think about what we do in society, we plan everything else. We plan birthday parties, we plan weddings, we plan
retirement.
Children, we plan retirement. So it's always kind of been a little perplexing to me as to why people don't plan their own health care or how they would want things to go. But I think it comes down to that people are just uncomfortable.
Very. The majority of people are very uncomfortable. And I was in an initial consultation yesterday, and a dear family, and the woman was tearful. The patient was tearful. She's younger than I am.
Yeah.
So yes.
Expected.
The son was very supportive. It was very sweet. It was very supportive. But we let her cry.
Sure.
I said, this is a normal reaction. If you didn't cry, then I might worry more.
Right.
I said, this is hard. These conversations are hard. And unfortunately, a lot of providers, a lot of people in the healthcare field do not feel comfortable having them.
Right.
Not only do the families not want to talk about it, but sometimes they may not.
Yep.
So I encourage you to ask your provider. You may be 35 in perfect health as far as you know, and, just ask my provider, I think I need to do a living will. because that's the first thing you can do, which is an advanced care directive that just says, if I get to this point where I'm dependent on a machine to breathe,
Right.
or I'm dependent on a tube to feed me if I can't swallow. And we all know there's young people that pass away or come close to that with brain bleeds or things that you don't even know you're walking around with.
Right.
And how great would it be, what a gift to your family to know that you've already written it down. It's on paper. It's been notarized. Even if you don't go have it registered, that's the best. But even if you don't have registered at the courthouse, as long as it is written down, your wishes, and it's notarized with 2 witnesses that aren't part of your family or your healthcare family, and it's legal.
So let's talk about that, the different advance directives. So, right, what you were just describing is a living will. Any particular resource that you could share?
Well, my favorite is 5 Wishes.
Yes.
And it's been around for a long time. You can go on the website, and it's the digit 5, I believe.
That's right.
Wishes.com maybe, or .org. And for $5, I think it is, it might have gone up now, but for a minimum amount, you can get the book mailed to you, or you can download it.
Okay.
And once you download it, or we have copies here.
Right.
We can't provide them for everybody because they do come at a cost. But certainly reach out to us if we can. And there's also, if you don't do the 5 Wishes, you can go on the North Carolina websites, because every state is different. And it has its own advance directive.
Okay.
And it includes a North Carolina power of attorney. Not a financial durable power of attorney, but one regarding healthcare only. And it leads you through that. Or, your provider, if you take it into the office, or if your office visit, I would call and let them know that that's one of the things you want to talk about during your visit, because sometimes they want it to be a separate visit, and that's okay. They won't do it telehealth. It needs to be in person, because these are really tough decisions, and they want to make sure you know what you're talking about before you say, I don't want this, or I do want this. So, but those are the 2 almost free resources. But 5 Wishes is my favorite, and I'll tell you why. It starts at the beginning, and it wants to know everything you want from the time you get sick to the time after your funeral. So even if you don't fill it all out, it gets the cogs going.
Right.
And you start thinking, well, when I'm sick, okay, so perfect example is when my dad was sick, always, even if it was just a headache, he wanted to be left alone. He didn't want any lights on. He didn't want any noise. But some people want everybody around them talking. Right. And the children playing around the bed. They don't mind. So everybody's different. So I think it's important. That's where you can decide, well, maybe I've never thought about that. What kind of music do I want? I want James Taylor played at mine.
Yeah.
Or, while I'm going, or I want gospel music played. All those, which seem like minute details, add up to a plan that your family can follow. And it's such emotional ease for them. It's still not easy.
Right.
But it reduces the emotional stress of the time.
And especially with our hospice service line, I think we have seen over and over, again, not easy, it is always difficult, but I think our bereavement team would back us up on this, that if somebody has had a plan, and like you said, such a gift to the family, because when the family can know in their heart, we did exactly what so-and-so asked us to do. This is exactly what they wanted. So it eliminates that emotional second guessing.
Yes.
That the family may go through if there's not an advance directive in place. So
I took care of a man a couple of years ago whose daughter-in-law was an ex-daughter-in-law actually, but very close to the family still, was in on the conversation in the home. And he wanted everything done. And then he says, but when I get to that point, my children can make that decision. And we hear that quite often. And this daughter-in-law, she says, now I don't have any say-so anymore. She says, but I'm just going to tell you, I had to make the decision to take my mom off a ventilator. And I'll never forget it or get over it or get over the guilt.
Right.
And so if you know you've done your best, You fulfilled the wishes of your parent or your spouse or your child, and that eases the grief.
Right.
It makes it less complicated.
Right.
But when you take grief and stress and guilt and post-traumatic stress, and you put those together, that is a grief that may take years to overcome.
Right.
And professional help.
Absolutely. So we have to acknowledge that these are difficult conversations to have. It's difficult to think about it for yourself. But what suggestions do you have if there are folks out there that maybe need to start having this conversation with aging parents, let's say?
Well, I had to have the conversation about 3 times with my mom. My dad had dementia, so by the time, and he refused to talk about death. So with him, my mom and I made the decision, and my brother. But with Mama, who does not have dementia, but is declining and is in her mid-90s, I had to have the discussion maybe about 3 times. And she changed her mind the older she got. First, she wanted a feeding tube. Then she had a sister who had a feeding tube for 9 years, laying in a fetal position in a nursing home.
And that changed her mind.
That changed her mind about that. And now she says, I don't want to go back to the hospital. I don't want to have any kind of surgery, any kind of testing done. We are comfort only. So it's not something that you just jump into a lot of times.
Not a one and done.
No, it's a gradual series of conversations. But I think that's okay. And to let them know, you don't have to decide everything today. Let's just start somewhere.
Just start somewhere. Right. And I think just letting people know, I think being honest, this is going to be a difficult conversation. This is hard for me to talk about. This is going to make both of us a little uncomfortable. Any kind of opening.
I always start
like
out the conversation with that very first sentence. On our first visit, we have this very difficult conversation, so we're all on the same page.
Exactly.
And we'll revisit it as needed.
Well, and that's a conversation I've even had with my own parents, and that's how it got started. Because my brother and I want to make sure we are fulfilling their wishes. So I literally told my folks, I said, I will support whatever you want done. I've just got to know what that is. You know,
Yes.
And again, let's avoid a crisis situation.
Yes.
None of us are going to make a good decision. Then it's going to be a very emotional decision, and you've potentially, in my opinion, kind of set people up to be at odds with one another if you wait till there's a crisis. This way, if you can...
And if there is one sibling that's not on board with what the major ones do, then, you know, sometimes it takes one person longer than the other. But there's a legal... if there is no document, there is a legal order to which everything needs to, as far as the decision making. But there's no sense in making it hard on everybody. It's easier if it's talked about earlier, and include the family, especially depending on the family and the area of the country you live in and the culture, and even, I would say, even your ethnicity has a big deal, has a lot of impact on how it's handled.
Right.
In some families, it's a family decision.
Right.
In our family, it's my mom makes her own decisions. But different cultures handle it different too. And so we're so blessed to have chaplains and social workers who that's their, I like to consider myself culturally informed, but not always.
Right.
And so I always will ask one of them, is there anything I need to know that would be different because of maybe their religion or their, their culture. And because that can make a difference.
Sure. So then we go back to what you said earlier. That even comes down to what makes individuals unique, right? And what their values and their priorities are, and how that's going to guide these conversations.
But if you ask someone even though they don't always know how to answer the question, what's important to them, we all know that dignity is something that everybody values.
Right.
I mean, I've never met anybody that didn't value dignity and independence. If our patients are depressed, most of the time it's because they've lost their independence.
Sure.
So anything we can do to make them feel like they're still
part
themselves.
of the process. They're themselves. They're still in charge of their own decisions.
They're the captain of their ship still.
That's exactly right.
It makes a huge difference.
That would be important to all of us, I think.
Mm-hmm.
So I don't know in my career that I've ever seen somebody have an advance directive in place, have it carried out, that it caused a problem, necessarily. What, though, do you see as a provider, and maybe in our serious illness care program, or just over your career, have you seen where not having something in place, not having something in writing, caused a problem?
Well, I've been a nurse for a long time. But when I was working in ICU, my first 15 years of my career, I had a lady who was in her 90s in ICU on a ventilator. And she actually arrested hourly for my 12-hour shift.
My goodness.
And we kept asking, the doctor to have that was back in the day before advanced directives. And so, they did everything as long until somebody said stop. And I had a nurse come in who was more seasoned than I was, come in on first shift to relieve me. And when I told her what had happened, she said, "What?" She says, she grabbed me by the arm. She says, "We're going out to talk to this family." And we're grabbing the resident at the time. It was a teaching hospital. We're grabbing this resident, and the three of us are going to go talk to this family. And we did. And the family said, "Of course, let's stop it."
Right.
But now we have this Advanced Directives Act since the 84.
84, 85, something like that.
So now we have this where people can put what they want, and it has to be followed.
Right.
But I will say this. If somebody has just the advanced directive and there's no DNR or most form, which are two other forms that go into more detail and are legal doctor's orders, there may be times when those are not followed because there's a surviving family member, daughter, son, spouse, child, that says, "I don't care what she put." We hope that doesn't happen.
Right.
And I've not known that to happen in a long time. But at first, it was a big transition for the healthcare community to honor those. So it's important to have your copy. If you have these in place, like I use my mom as an example all the time, and I know she probably knows it. But she has her durable and her healthcare power of attorney, which is me, and then she has two alternates. And then I have a copy, and she has a copy where she lives. And then her DNR, I don't have a copy of that or her most form, but where she lives is a copy.
Right.
So that way we know. So anybody who is involved in that process, if there's 2 or 3 people for healthcare power of attorney,
everybody needs
a copy.
Yep.
And then I tell them to keep a locked copy somewhere that's safe. But it's important to make sure that I even have my mama's on my phone because some people won't talk to you about anything unless you have it. And even though it's not the legal copy, a lot of times it works temporarily. But it needs to be done early. It needs to be as complete as possible. But the starting place would be the advanced directive and living will.
Yep.
Because the phrasing in that says, if I'm to the point where I'm in a persistent vegetative state.
Right.
Well, there's a long ways between sitting here like we are and a persistent vegetative state. And so that's where the DNR and the most form come in. And, they can choose how aggressive that they want the hospitalist to be to take care of them and whether or not they even want to go to the hospital to start with.
And as things change,
it can be changed.
They can go back and change it. And I think that's an important thing for people to realize. Just because you put this in writing now, that 2 years from now, 6 months from now, 5 years from now.
There's actually maybe a half a dozen lines on the back of the most form for half a dozen changes.
Gotcha.
Because people pass away.
Exactly.
And so you have to make changes.
Things change, but it can all be updated.
That's right.
Okay.
It's not written in stone.
That's important to know. Yeah. So without, of course, sharing any confidential details, can you tell us about a moment that just reinforced the value of having these conversations early?
Yeah, a couple of weeks ago, I had a daughter of one of our former patients who passed away suddenly. She was on her serious illness program, so she had chronic serious illness, but not hospice eligible. And she had a sudden cardiac arrest. And because she could talk, her children were leaving it up to her. And the decision never was made to make her a do not resuscitate. And as a result, those two children watched their mother in her 90s be resuscitated. And she just cried.
I can only imagine.
She says, I'll forever have that image. That's the last image that I have of my mother. And she says, I begged them to stop. But they have rules that they cannot stop until certain conditions are met.
Right.
And if there's any chance that a fall caused the death, then it's a medical examiner's case, and they absolutely can't. They have to do everything. And so, it was just sad.
Yeah. Well, that really reinforces not only, so obviously at some point they had the conversation, but leaving it up to the individual, but it really reinforces having all of the advanced directive straight through to that DNR, having it in place. Because had they had that in the home,
because I even had to look back at myself and what I did that day, or the 2 times we talked about it, and think, well, should I pushed it? But these are conversations that it's hard to push with the family. But the last thing she said to me after, I'm not a bereavement counselor, but I just listened. And she said, the last thing I would ever want anybody, I wouldn't work, quote, I would not wish this on my worst enemy. And I said, if it ever comes to, I talk about this to different groups. In fact, we had already, and I said, is it okay if I tell your story without any personal information? She says, absolutely, if it helps one person.
And there you go. Probably help more than one through this conversation. So that is awesome.
Yeah.
Can you think of anything that we have left out? I feel like we have covered things, but if there's one thing that you would want people to remember from this conversation, what would you want it to be?
If you have access to a website, or the next time you go to your doctor, and you may be somebody that doesn't go to the doctor much, so you can get on a website, but you need to have the conversation around a family get together, or whenever, if you have adult children, when they're around, you need to include everybody. Don't leave anybody out that's going to be impacted, because they won't feel left out. But make the plans as early as possible. As nurses, we used to laugh about having DNR tattooed on your chest. Totally inappropriate to do, but in other words, have it done.
Have it done.
And it may not be to that nth degree. It may be just saying, if I'm ever not able to talk or walk or whatever, whatever is important to me. If I can't do those things that are important to me, then that's when I want you just to keep me comfortable.
Right.
Whatever the decision is, it needs to be done early. It needs to be in writing, because people forget, or people don't want to talk about it when the time comes. And you're inundated in the emergency room. Have you ever been with your parents in the emergency room?
Absolutely.
And there's questions coming at you by the dozens. And your head's spinning. You don't know what to do. But if you already have it made, all you have to do is hand
Here
them.
is this. Yeah, here's the plan.
And if your doctor or your provider, whoever you see, that's your primary care provider, if they don't bring it up to them.
Exactly.
and say, I've been reading about this. I saw Ancora's podcast, and I want to talk about this. I want to make an appointment to talk about this. Do you have the forms, or I need to bring them with me? They should have them there.
Right.
But if you go ahead and just be proactive, go ahead and have the 5 Wishes book or form, or the form from the state of North Carolina, take them with you, and they'll fill them out right there. And Medicare and private insurance will pay for those visits to have those discussions. So it's not like you're going to have to pay out of pocket. So
Awesome.
anyway, I can't encourage people enough to have it done.
Good advice. I appreciate you being here. We hope you learned something today. We hope you paid attention to the resources that are available. If you have any questions about how to start having a goals of care conversation or initiate advanced directives for yourself, for somebody that you love, give us a call at 336-427-9022.